welcome. Good morning, good afternoon, good evening. We have participants who have registered from over 32 countries, and we welcome you all to Dry Eye Desert 2020. First off, Dr. Gupta is an associate professor of ophthalmology at the Duke Eye Center. As a prior Duke Cornea Fellow myself, I can tell you firsthand that she is a dry eye disease queen and has really moved forward the use of intense pulse light therapy for the treatment of dry eye disease. And she is on the Ophthalmologist Power List 2020 Top 100. So without further ado, I am grateful and I hand it over to Dr. Gupta to deliver the lecture, Dry Eye Correction, Management of Post-Refractive Dry Eye Disease.
Thank you so much, Ashiana. So we are going to spend the next 7 minutes and talk a little bit about ocular surface as it relates to our refractive surgery patient. So those are my financial disclosures. So how does dry eye negatively impair our outcomes? I think this is just really important for us to understand, to allow us to feel and understand why ocular surface disease is so important. It impacts our preoperative measurements. You can get irregular topography, unreliable refraction. Postoperatively, even a bigger issue, patients don't see as well if they have ocular surface disease. They can have blink to blink variation. There's increased higher order aberrations, which may even be magnifying the higher order aberrations that we might see as part of ordinary refractive surgery. And then last but not least, our patients are not happy when they're dry after surgery. Patients, often will come in and they'll see 20/20 and we'll think, well, what's the problem? But they're unhappy because their vision quality is degraded through the process of damage related to ocular surface disease. And there's just a feeling of, you did this to me. Dry eye is certainly out there. When we look at what's in the literature, one study reported it to be as high as 40% of patients presenting for laser vision correction. Contact lens wearers are certainly at risk for dry eye disease. And honestly, contact lens intolerance is a huge issue for patients and is often a presenting reason for why someone might actually go and pursue refractive surgery. So I have a little case here. This is a patient that came in. She's 28, wants to see if she's a candidate for LASIK or PRK. She's not happy because she can't wear her contacts anymore. And as I mentioned, when I see that, or when I hear patients say that, I kind of have my antenna up and I'm looking for any sort of ocular surface disease. She's an average myope. She does correct to 20/20, but let's start by looking at her topography. You can see that there's missing data. There's a little bit of irregular astigmatism. And when we look at her clinically, she just has a few corneal stains on the surface, but she has MGD and a reduced tear breakup time. She has an abnormal osmolarity, but a normal MMP9 test. And we recently published, or in the process of publishing, a study where we looked at how common meibomian gland atrophy is in our pre-refractive patients. And it's actually much more common than we realize. And so I've incorporated meibography as part of a standard evaluation in my LASIK and PRK evaluations, because often we'll look at the meibomian glands, we'll be able to see if there's dysfunction or not. But I'm so often surprised at how patients may actually have more severe atrophy that we just don't recognize. And that to me is someone that I would consider to be a high-risk patient. So let's talk a little bit about risk. So if we don't treat ocular surface disease before surgery, well, we know that they're going to get worse afterwards. Several studies have documented that the tear breakup time reduces, that corneal staining increases, and patients become more symptomatic immediately postoperatively. Well, and then if we fast forward that to several months to years plus after refractive surgery, the prevalence of OSD in the literature is quite variable. So in one study at 1 year, the incidence of chronic dry eye was 5% in PRK and about 1% in LASIK. Another study reported 8% at 6 months, and another one reported up to 35% at 6 months. So definitely there's some variance in the literature, but I think it's a clear message to all of us that we really need to be addressing this before surgery. So what should we do with our patients? Well, there's so many different algorithms. There's the TFOS-DUES-2, which was published in 2017. There's several tests that we can do. Last year, the ASCRS Corneal Clinical Committee, which I'm part of, published an algorithm for looking at the preoperative patient, whether it's cataract or refractive, and suggesting a series of steps to follow to diagnose and also guidance on treating ocular surface disease. This is readily available at JCRS. So what are the things that I look for? I think we all want to be efficient in our examination. So I always look at the lid margin and the ocular surface. And then there's several different point of care tests. I mentioned, MMP9, osmolarity, tear breakup time, that's non-contact, meibography. And by no means do you have to incorporate all of these tests for all of your patients. But I do think that tear film diagnostics do help to identify dry eye disease at an earlier stage. And especially in our, cash pay premium patient, I think that it definitely adds value to be able to diagnose these patients. This is from the ASCRS preoperative algorithm. And I put this here because, a good clinical exam will get you so far. And it's really important to, not just look at only the corneal surface, but look at the eyelids, look at how patients are blinking, look at their upper, pull their upper lid, look at the superior cornea, because you can often find a lot of pathology there. And then gently pushing on the meibomian glands. And then I use a strip of fluorescein and just gently wet that with a drop of BSS or proparacaine and place that in the inferior fornix. And that gives so much information. You can see how the tear film's dissipating. You can measure tear breakup time, and you can also assess the conjunctiva. So MGD, well, we all know that MGD is one of the most common causes of dry eye, and it doesn't always have to look like this, where there's thick, ropey secretions. Sometimes it can be non-obvious, and really only unless you push on the meibomian glands will you see that there's actually thickening of the secretion and poor flow of the oils. We talked a little bit about meibography and the importance of meibography. I really like it because it's a picture and it's very descriptive, and it allows us to have a conversation with our patients. So what do we do with these suboptimal patients? Well, I always say that treating dry eye doesn't have to be difficult. There can be over-the-counter treatments, topical medications, and then in-office treatments. So I think any patient is a candidate for tears, compresses, scrubs, omega-3s. It is important that once we initiate a therapy that we do see them back and repeat measurements and look for progress. Topical therapy. So not all of my patients get, a molecule like Xiidra or lifitegrast or Restasis or a topical steroid, but patients that have documented corneal staining, that staining has to be resolved before they can proceed to surgery. And so often, I am using one of these molecules to help with that. And if I think the patient is at risk for long-term dry eye, I might, even start a topical steroid for a brief pulse and then add either lifitegrast or cyclosporin, because those drugs do take longer to activate. In-office treatments for MGD, there's several that are out there. They're highly effective, and these are things that can be done preoperatively to help mitigate some of that postoperative decline in the tear breakup time, as well as worsening of symptoms. So what has data? I always like to look in the literature here as we wrap up. Well, omega-3s have been shown. If you take 1.2 grams a day of a triglyceride formulation, that patients had less conjunctival staining and a lower OSDI. Lipoflow thermal pulsation was shown. This was a study in 2017 that was published in JRS, and they used it to treat recalcitrant post-op dry eye disease symptoms after LASIK. And they did find that patients improved in their tear breakup and had a reduced speed score. There's evidence in the literature that cyclosporin can help to increase Schirmer's over time. And then, of course, punctal occlusion. Sometimes we forget about this as a treatment, but I love it in my refractive patients because it can be used temporarily while they're initially worse off, and it can be removable. So in summary, I highly encourage all of you to diagnose and identify dry eye before you operate to avoid refractive surprises and unhappy patients. As we reviewed, treating dry eye does not have to be difficult, but it just requires taking that additional step to make it part of your protocol so that you can identify these patients early.
Dr.
Thank
Gupta,
you,
thank
Jana.
you very much. That was fantastic. Next up, we have Dr. Syed, who will be giving us dry or wet dry eye disease diagnostic tools. A little bit about Dr. Syed. She is Cornea Fellowship Co-Director at the Wills Eye Hospital and alumni of Harvard University for her undergrad, Harvard Medical School, Massachusetts Eye and Ear Infirmary for residency, and has completed her Cornea Fellowship at the Bascom Palmer Eye Institute. All very, very impressive. We are in for a very, very fun treat with her multiple choice questions. Dr. Syed, over to you.
Hi guys, thanks Ashiana for organizing such an awesome session this morning or evening, depending on where you are. Like you said, I'm Zeba Syed. I'm coming to you from Wills Eye Hospital Cornea Service, and I will be doing a multiple choice question series on dry or wet dry eye diagnostic tools. So I just wanted to mention that Dr. Gupta covered a lot of the myopography and touched upon LipiView, LipiFlow. So I did want to mention that my questions today are going to be kind of more experimental dry eye diagnostic tools, things are that are kind of on the horizon, things that we may not have exposure to, we may not have seen yet, but this is kind of what I've been assigned the task of. So these may be tools that we have not necessarily heard of yet. All right, so no relevant disclosures. Like I mentioned, some of the technologies I'll be discussing are ones that I personally don't have experience with, just because many are still experimental. Question 1. A 54-year-old woman with Sjogren's syndrome undergoes corneal thermography testing. Compared to control populations, corneal thermography in aqueous deficient dry eye disease demonstrates A, higher average ocular surface temperature as compared to control populations, B, similar average ocular surface temperature, C, lower average ocular surface temperature, or D, none of the above.
So the way it works for the audience, give your best guess, A, B, C, or D, pick one. It's not an easy question that Dr. Syed has started us off with, but we'll have about 10 seconds to have everyone sort of chime in. We've got the large majority going with A. Dr. Syed, okay. Are we on track?
So let's see. So the correct answer is C, and I will tell you guys why. So corneal thermography, it quantifies the ocular surface temperature at multiple test locations using a camera operating within the infrared range. So multiple companies make this corneal thermographer or ocular surface temperature monitor. Tomy makes one in addition to other companies. And basically, the higher the temperature of the surface, the higher the power per radiating area. So as you can imagine, it's fast, it's non-invasive. It outputs a map that looks something like this, where you kind of see the temperature of the ocular surface can be color-coded and pretty visually understandable. So what happens in dry eye disease? Well, here is a paper. This is the results from a paper that came out a few years ago in Ocular Surface. And on the left here is you have the patient blinking, and then seconds after blinking, basically the eye being open after the blink. And along the right, you can see the temperature associated with each color code. So a normal eye, you blink and you have pretty warm temperatures here. So, you know, in the 36 range, and as the eye stays open with time, it cools off to the, you know, the 34, 35 range degrees Celsius. Here's evaporative dry eye and aqueous deficient dry eye. So both of these are much cooler than the normal dry eye upon opening. So that was our question is, you know, it's lower average ocular surface temperature in both dry eye populations. So you open the eye, it's much cooler in both dry eye groups. It is even cooler in the aqueous deficient dry eye as compared to the evaporative dry eye. Plus, the rate of cooling is higher in the aqueous deficient dry eye. So not only does the aqueous deficient dry eye have a cooler starting temperature, but it continues to cool faster than the evaporative dry eye group. And so to summarize, corneal thermography in dry eye patients have cooler ocular surface temperatures. Aqueous deficient dry eye has cooler mean temperatures, and they have a faster cooling rate as well. So does anyone on the panel have any experience, either experimentally or at all, with corneal thermography? I know that very few companies are making it, but wondering if anyone has had any personal experience.
No.
Yeah, maybe not, because it's still so experimental. But
it seems so illogical.
Right?
Evaporation produces cooling. We've all learned that.
Yeah.
It would be heat. You would expect it to be heat, correct?
Yeah.
I think that part of why, we might look to the evaporative component, but some have suggested that if there's excess cooling, that the meibum actually isn't, like, that contributes to the quality of the meibum. And,
Okay.
If it has a lower melting, a lower overall temperature, that it might not be as liquid. But I think one of the issues with a device like this is you could use it as a screening tool, but it might not be as meaningful as something to serially follow the patients, since it isn't necessarily, there isn't an exact metric, for example.
Correct. No, I totally agree. But I think it's definitely an interesting finding, and something, that we can just kind of keep in the back of our heads as something that's out there.
And out of curiosity, Dr. Syed, how much does this cost?
I don't actually know the cost. I've not looked into the company. I imagine it's very expensive, though. A 24-year-old man with severe rosacea undergoes tear film imaging. Lipid layer thickness, as demonstrated using tear film imaging, demonstrates, as compared to control, A, consistently thicker lipid layer across the cornea, B, a consistently thinner lipid layer across the cornea, C, unable to quantify, or D, a highly variable lipid layer thickness across the cornea.
And we have A's.
Consistently thicker?
Consistently thicker.
All right, so the literature shows a highly variable lipid layer thickness across the cornea.
Oof.
And so let's go through this. So this paper came out earlier this year by our very own Dr. Galor. It was one of the authors. And basically, tear film imaging uses spectral interference to image the corneal surface. It measures the mucoaqueous layer thickness, lipid layer thickness, can assess for changes over time. The company that makes this is based in Israel. I don't know how many other companies make it, but this is the one that I was most familiar with. And so here's an example of an image from that paper showing the lipid layer thickness map on the left of a control subject. And you can see here, it's pretty homogeneously similar thickness, about 20. And here's the lipid layer thickness map of a dry eye patient. And you could see it's very variable. The thickness ranges anywhere from 20 to over 120, and you can't use any single point to represent the thickness on that ocular surface. And so in that paper, they showed that the mucoaqueous layer thickness was thinner in dry eye groups. The mucoaqueous layer thickness significantly correlated with the Schirmer score, and the lipid breakup time correlated with the tear breakup time. So Dr. Galor, what are your experiences with this technology, or what did you find interesting when you did that study?
So first, it's a very novel technology, and it can image the tear film to a nanometer resolution. There's no other machine that can get that resolution. So you're able to, for the first time, to really quantify the mucoaqueous layer, which you can't typically do with our other devices. And this the findings from the study reinforce what we get a sense of from the LipidView, where they do give you a central thickness value for the lipid, and it doesn't seem to correlate clinically with disease status. And the reason is you can't look at any one point centrally and get the whole story, because you could have a thick, unstable, or a thick, stable, thin, unstable, thick, thin, stable. So you really need to understand the stability and the distribution in order to understand what's going on with the lipid layer. And so this machine isn't in practice yet, so I only have a very limited experience in a small number of patients, but I'm hopeful that it'll give me a bigger dynamic picture of what's happening than what I have so far. So let's see. It's a neat technology.
Thanks for that insight. All right, so in the interest of time, we'll keep moving. So question three. Question three, an 83-year-old woman with severe MGD undergoes confocal microscopy testing. What feature of MGD is demonstrated in the abnormal in vivo confocal image shown here? On the left is a normal image, and on the right is the patient. And so what feature of MGD is shown in this image on the right? Take a look again at that image on the right. And so is it A, intraepithelial and interglandular inflammation? Is it B, lumen obstruction? C, glandular fibrosis? Or D, is this just a normal variant and I'm trying to trick you guys?
No, it's across the board, A, B, C, and D.
The correct answer is A. Vivo confocal microscopy, as many of us are familiar with, it allows imaging tissues with cellular resolution, and it allows us to measure parameters like meibomian gland diameters, inflammatory cell density, and gland acinar unit density. These show great sensitivity and specificity for MGD diagnosis. So in this paper that came out last year, they showed this kind of categorization of MGD according to confocal appearance. So you have type 0 is a normal meibomian gland. Type 1, you have lumen obstruction. Type 2, you see these interglandular and intraepithelial inflammatory cells. So we see immune cells as these hyperreflective structures that range in size and that kind of span across different parts of the glands. And then type C, of course, is the most advanced form with fibrosis and destruction. And so here's an example of using confocal in the assessment of MGD. Last but not least, question 4. A 52-year-old man with moderate dry eye undergoes anterior segment OCT evaluation. Which of the following cannot be assessed using OCT? Is it A, tear meniscus area, B, tear film composition, C, tear meniscus radius, or D, meibomian gland length?
It's a straight up B.
Yeah,
all the answers that
Great.
are coming in.
I should have reversed my order of questions. I feel like everyone did really well on the last two.
Good job.
And
guys.
so this paper came out last year talking about the assessment of the tear film and tear meniscus parameters using ultra high resolution OCT. So this group had a custom built ultra high resolution OCT system for which they measured various tear meniscus parameters such as volume, depth, area, height, curvature. And their findings are shown very nicely here. So using OCT, they were able to measure the tear meniscus area, the height, the depth, and the radius. And they quantified that very nicely in this paper. This reference is at the bottom left here. In addition to tear meniscus parameters, studies have also shown the use of OCT for evaluating the meibomian glands. So on the left here is a normal, quote unquote, normal or control patient. And on the right is OCT of the meibomian glands in a patient with MGD. And what the authors showed here was that the patients with MGD had more plugged orifices. They had shortening, distortion, and dropout of the meibomian glands. Especially as we kind of get out here, we see that dropout. And so that's it. You guys did great on the questions. Thank you guys for participating. And thanks, Ashiana, for organizing this awesome session.
Dr. Syed, thank you so much. That was awesome. Before I go into the next segment, I just wanted to highlight next month's course, Ophthalmology Gadgets and Gizmos 2020, looking at sort of all of the latest in technology. Dr. Syed has already started us off, but this is researchers, ophthalmologists who have really sort of moved mountains in things that are in the pipeline, from electrical stimulation for optic nerve regeneration, the Vivior Monitor artificial intelligence device, autologous retinal transplantation. So stay tuned. It's exactly 3 weeks from today. So moving on to at risk, addressing risk factors in dry eye disease. I have no relevant financial disclosures. Now, we are all aware of the decreased quality of life and economic burden secondary to dry eye disease, depression, anxiety, and reduced work productivity. Surely prevention is key. The questions we must ask ourselves: number one, what are the modifiable risk factors in dry eye disease? And number two, how do we best address prophylactic measures in view of these known modifiable risk factors? Now, we know through the dry eye workshop DEWS 2, the foundation has already been laid with regard to modifiable risk factors, including contact lens wear, environment, medications, but we also need to know the non-modifiable risk factors, including age, female sex, Asian race, and so forth. And why is this important? Because we need to really understand whether it be modifiable or non-modifiable risk factors. Can we potentially apply knowledge, knowing that these risk factors exist, to implement and initiate preservative artificial tears, for example, or other prophylactic therapies before signs or symptoms develop? Now, beyond these risk factors, the Dry Eye Rhythm was an app released by Apple in Japan in 2016 and in the United States in 2018. Used for dry eye research, it was downloaded by over 18,000 users. And the app is quite simple. It used simple blink tests to screen for dry eyes. It tracked daily changes, established a dry eye map, and had questionnaires on demographics, medical history, lifestyle habits, and the OSDI. Aging in this study, interestingly, was inversely correlated to the severity of dry eye symptoms, suggesting that the younger population may experience dry eye symptoms that remain undiagnosed. Other risk factors significantly associated with severe dry eye were female sex, collagen disease, hay fever, depression, current contact lens use, extended screen time, and a positive history of smoking. And the question still arises: how can we implement change prophylactically for patients with any of these risk factors? So here's an example of a long-standing history in an Indian male of viral endotheliitis bilaterally and requiring a penetrating keratoplasty. Preoperatively, what are the things that could have been done? Well, we could have established a pact with the patient that he quit smoking prior to surgery, given the risk of graft failure. Surgical intervention of an amniotic membrane concurrently with the penetrating keratoplasty. And it's not just with PKs. I was speaking to a retinal surgeon colleague of mine at the Duke Eye Center, and he was telling me how he initiates, through the collaboration with the cornea team, staged procedures doing amniotic membrane prior to vitreoretinal surgery. It's something that we use in a variety of ocular surgeries. And finally, this patient could have received autologous serum tears, or PRP, in the immediate postoperative phase and aggressively. A study was published in Contact Lens and Anterior Eye looking at tear lipid supplement prophylaxis against dry eye in adverse events. Looking at this concept of prevention, 30 patients with symptomatic dry eyes were randomized, double masked, and paired eyes were implemented. One to lipid drops, sustained balance, versus the other eye, the control eye, to non-lipid drops, sustained ultra. Subjects were subsequently exposed to a simulated adverse model, which was basically a fan. And both therapies, it was noted, resulted in increased non-invasive breakup time and prevented its decline below baseline. And although the lipomimetic drop sustained balance increased the lipid layer grading, both conferred protective measures against exposure to adverse environmental conditions. So the question is, if it was your patient at risk, why wait? When we know the risk factors are present, even in the absence of symptoms or clinical findings, and yet this has to be further investigated for sure, but why not take the prevention rather than waiting for dryness to surface at all, preferably electing for preservative-free options that have little to no toxicities, and for ocular surgery, perhaps a combination of both medical and surgical therapies, such as amniotic membrane, punctal plugs. So in conclusion, understand the modifiable dry eye disease risk factors and how to best implement management. Number 2, risk stratify and consider initiation of prophylactic dry eye therapies and early. And finally, consider a combination of both prophylactic, medical, and surgical dry eye management. And I like to dedicate the work that I do to my spiritual master, Dada J.P. Vaswani, who is titled as Saint of the Century, and whose meditation we will be hearing shortly. Next up, we have Dr. Anat Galor. Dr. Anat Galor is Associate Professor of Ophthalmology at the Premier Bascom Palmer Eye Institute. She has numerous positions, including serving on the editorial board of the Ophthalmology Journal and chairing of the American Academy of Ophthalmology One Cornea Network, to name just a few, and is the author of numerous publications that focus on dry eye, ocular surface tumors, and the cornea. Dr. Galor is herself a dry eye workshop 2, DEWS 2 workshop subcommittee member on pain and sensation, and will be teaching us through Test Your Memory, DEWS 2 workshop multiple choice questions. Dr. Galor, thank you so much. You are awesome. Thank you for being with us today.
Thank you for having me. So let's start with the question. All right, hopefully these are going to be either easier or harder. I'm not sure than Zeba. So question 1. Okay, which corneal nociceptor senses evaporation and is thought to be involved in sensations of dryness? A, B, C, or D?
We're between A and D on the answers.
All right. The answer is actually C, cold thermoreceptors. So just as a reminder, there are 3 main types of primary nociceptors in the cornea, and their job is to sense the environment. And you can put your little probe in and look at the firing pattern and identify the different types. So type 1 are mechanoreceptors. So if I poked you in the eye, they would fire. About 20 to 30% of the axons are mechanoreceptors, and they are thinly myelinated. Then you have these polymodal receptors. They sense everything: capsaicin, heat, carbon dioxide, mediators of inflammation. And most of them also sense touch. And that is the majority of the peripheral nociceptors. They're unmyelinated. And then you have the cold thermoreceptors. They were the last to be discovered, and they are the ones that sense evaporation. They make up about 10 to 15% of the axons. They're also unmyelinated. And they are the sensors. So how do they sense things? And it turns out they have these channels on the terminal nerve endings that are continuously interacting with the environment. So the TRPV1 channel is the one that's on polymodal receptors. That one is thought to mediate burning and unpleasant dryness. And then you have the TRPM8 receptor on the cold thermoreceptors. They sense evaporation, and they are thought to mediate the sensation of dryness. I need more tears. Question 2, where does the primary nociceptor meet the second order neuron? Getting you guys back to your anatomy days.
We are getting a combination of A, B, and C, Dr. Galor.
All right. So the correct answer is A. And I just want to remind you of the anatomy. So the cell bodies of the primary nociceptors, the one that had the little channel sensing the environment within the cornea, that's in the trigeminal ganglion. But the synapse between the primary and the second order neuron, that's in the trigeminal nuclear caudalis. And there are multiple little subnuclei. So there's the VIVC area. That is the one where the dryness, I need more tears pathway is sensed. And then there's another one, that's the VCC1 area. This is all the trigeminal nucleus caudalis, just different areas. That's the one where those polymodal neurons send up the information that says, hey, burning, unpleasant dryness. And then the second order meets the third order neuron in the thalamus. And then from there, it goes to the brain. But what we often forget, it's not like there's just one part of the brain that says, hey, I sense pain. There is an area that is involved in the sensation of pain, the somatosensory cortex, But there's also other areas, the prefrontal cortex, the amygdala, the limbic system, involved in the emotional component of pain. And what's really interesting about eye pain is when someone comes in with eye pain, even if they say, okay, I have a 10 out of 10 eye pain, they have more of an emotional component to that pain as when they come in with 10 out of 10 foot pain or back pain. So there is something evolutionary that connects eye pain to the prefrontal amygdala limbic system, and it elicits a really robust emotional component that you don't see as much in chronic pain elsewhere. And this is something that we just need to accept when we deal with eye pain. We can't just ignore those connections. So we've been using the word pain a lot, but I think we should stop and go back and figure out what exactly are we saying. So a little time for definitions. So when I say the word pain, I mean an unpleasant sensory and emotional experience. And you can imagine when you think about the eye, there are different ways people can describe what they're feeling. Some people use the word burning, some sharp shooting, some dryness. And you can imagine if you felt dryness and burning in your eye all day, that would be an unpleasant sensory experience. It doesn't mean that the pain you experience is the same as what someone would come in with scleritis, just that when you say pain, you're thinking nerves. And the reason that's important in the nerve world, there are two different types of pain. There's something called nociceptive pain. That's something in your environment that's tickling the nerves and causing them to activate. So what causes nociceptive pain in the eye? Everything we just talked about. If I poke you in the eye, if you're exposed to inflammatory mediators, if you have fast evaporation, if you live in an air polluted city, all of that will trigger your nociceptors because their job is to sense the environment. Well, what's neuropathic pain? Neuropathic pain is when you have a problem within the nerves themselves. So they are firing abnormally. And why does that happen in the eye? Well, we're still learning about different causes, but lots of groups have shown that corneal nerves can become sensitized. So one group dropped an inflammatory soup on the cornea, and then they measured firing in the polymodal receptors. And they found that these polymodal receptors changed and had features that are consistent with sensitization. What does that mean? Things like spontaneous firing and firing to a greater amplitude with the same stimulus. If you take out the lacrimal gland and you stick a little probe in the thermoreceptors, remember those are the ones that sense evaporation, you can see again these electrophysiological features of sensitization, increased spontaneous activity, increased firing frequency. And it doesn't just happen in the primary nociceptors. If you take out the lacrimal gland and then you measure in the trigeminal subnucleus caudalis, remember where the primary and secondary order neurons meet, you can see these same features of sensitization. So it's not crazy to think that the same things can happen in humans. So let's summarize. We have nociceptive sources of pain, things like aqueous tear deficiency, abnormal anatomy, toxicity from glaucoma medications. But we also have peripheral sensitization. So we know that when we perform any type of eye surgery, we cut nerves and they can heal abnormally. And we know that some people have central problems, people who have had a traumatic brain injury or migraine or fibromyalgia. They can have central issues. And this is what we call neuropathic pain. The problem is it's not that simple, because if you have ongoing dry eye, anatomical abnormalities, toxicity, the nerves can eventually become affected and become abnormal. And if you have ongoing peripheral nerve abnormalities, that can become centralized. So someone can start with one thing and transition and have more than one thing going on. And if you didn't think that was confusing enough, there's another entity where the nerves don't sense as well as they should, right? We call that neurotrophic keratitis. But there could be a nerve that doesn't sense very well, and right next to it, a nerve that's abnormally firing, right? And so you can have neurotrophic keratitis with neuropathic pain. We see that in painful diabetic neuropathy, and we think that the same thing can happen in the eye. And the reason it's so important for us as clinicians to talk about this is you can have someone with corneal staining, aqueous tear deficiency come in and say, my eyes feel dry, burning, aching. But you can have someone whose ocular surface looks perfect and they come in with the same thing. And we need to sort it out. So how do we sort it out? What is the best way to diagnose neuropathic ocular pain? Is it with a clinical examination, meibography? We heard a little bit about that this morning. MRI, or EEG.
Based on the last question, as to do we have till to date any sort of objective measure to quantify eye pain?
So the problem is pain is not objective. Pain is a subjective experience. And if you look at pain outside the eye, people use generally like a VAS 0 to 100 or an NRS numerical rating scale 0 to 10 to quantify pain. But when you look at the brain, you see that pain is not just a sensation, it's an experience. And people experience pain differently depending on their genetic makeup and their spiritual beliefs and their coping strategies, because pain processing is actually much more complex than I touch you and you have a response. And so that's just the reality that we need to embrace when we do pain research.
So far, Dr. Galor, the answers have come in A, but I have to tell you that my favorite answer was that there's a missing option. Call Dr. Galor.
But I would, whoops, just took it away. No, the reason this is so important is because the answer is A. And everyone has A. You may not have B, C, or D. Everyone has A. So everyone in the audience can diagnose neuropathic ocular pain. You don't need to call me. You don't need an option E. How do you do it? Okay, there is no gold standard, but this is what I do. It starts with a standardized workup. You want to understand, what is your patient complaining about? I love standardized questionnaires, but the problem is sometimes they give you a symptom score and you don't understand the individual symptoms. So are we talking about pain? Are we talking about visual disturbances? Within pain, I want to understand chronicity and I want to understand descriptors of pain. Like, do they characterize it as burning? Do they have evoked pain? And when I mean evoked pain, I mean things like hyperalgesia and allodynia, which are more common in people with neuropathic pain. So hyperalgesia means something that hurts me a little, hurts someone with neuropathic pain a lot. And to me, when someone comes in and says, I'm so sensitive to wind, I think they're trying to tell me they have hyperalgesia, they just don't know the word. Allodynia means something that shouldn't hurt, hurts. When someone comes in and says, room light kills me, allodynia. These are features of neuropathic pain. It's important to know who your patient is. I always look for systemic autoimmune conditions, but I also want to look for things like anxiety, depression. You nicely showed that that's related with some sorts of dry eye subtypes, and chronic pain, because chronic pain, depression, anxiety, they travel with eye pain. I want to know what medications they're on. Are they using any devices? I do a fast but complete ocular surface exam, and Priya did a great job at going over it. With one fluorescein strip, I can look at tear volume, breakup time, staining, anatomy, quick but comprehensive. The key change is that I ask my technicians not to check pressure, and I use the proparacaine test as a diagnostic test. So I put a drop in. If they're not having pain before, it's not very helpful. But if they're having pain and after my drop they have no pain, I think that they have either a nociceptive or peripheral neuropathic component to their pain. And if they have persistent pain, then I'm thinking this could be central or non-ocular. Okay, so when do you start thinking that your patient may have neuropathic pain? If they have certain descriptors like burning, evoked pain to wind and light, if they have the right risk factors, if their symptoms outweigh their signs, and if they have persistent pain after proparacaine, start thinking about it. Easy, everyone can do it. But we want more, right? As ophthalmologists, we love objective measures. So are there adjuvant findings that can help direct you to thinking that someone may have peripheral neuropathic pain? And this is using the confocal microscope. I thought you were going to show me a beautiful picture of corneal nerves. You fooled me and showed me meibomian glands, which I've never looked at on confocal microscope. What would you look for within the cornea to suggest peripheral neuropathic pain?
Okay, large majority are going for D, but I'm seeing A's, B's, and C's as well.
All right, well, confocal microscopy can show you a lot of things. And this is an example of someone who is healthy. And what we typically look for in aqueous tear deficient dry eye is decrease in the nerve density and these activated dendritic cells, which we think of are activated immune cells. But Pedram Hamra has done really nice work showing that when someone has neuropathic corneal pain, the feature that he looks for are these abrupt endings of the nerves and their hyperreflective bulbs. And again, it's hard to know what these represent. They can represent the fact that the nerves are turning, but in other areas, we have found that if you see that, it can be a sign of a microneuroma or an area where the nerve has been abruptly hurt and then is regenerating in an abnormal way. And this is really still in its infancy as we apply it to the eye, but this is something I do look for. It doesn't make my diagnosis, but it's certainly helpful if I see it. Remember here that you're only imaging peripheral nerves though, and only a small area of them. So if the abnormality is central, you're not going to see it. But this is very helpful in looking at peripheral pain, causes of peripheral neuropathic pain. Now, it's not perfect because this is a 44-year-old female, occasional dry eye symptoms, low Schirmer's, but no pain. Actually, it's me. And I was so sad because I had a microneuroma, right? But then I didn't feel as bad because my 26-year-old research fellow who has never had eye surgery and has no pain and her tear parameters are awesome. I could not find nerves. I don't know what happened to them. All I saw was these weird, I assume, activated dendritic cells. So her confocal looked even worse than mine. So you have to put the confocal scan in relation to the clinical picture, right? If you scan a bunch of people that don't have pain, you're gonna find weird things. So I would say really nice images, really important information, but you have to put it in the right clinical context. So what is the punchline? This is what I think, well, two punchlines. Number one, I hate the word dry eye. To me, dry eye is an umbrella term, and it can mean so many different things. Are we talking about symptoms, visual disturbances? Are we talking about aqueous tear deficiency? Are we talking about meibomian gland dysfunction? So I like to be very specific. Am I talking about symptoms? Am I talking about signs? Am I talking about a specific subtype? And then beyond that, I think that we have such a great way of subtyping dry eye into aqueous tear deficiency and meibomian gland dysfunction, but we forget that nerve status has to be considered when evaluating a patient with ocular pain, because ultimately they're having pain because their nerves are being activated, and we need to figure out why the nerves are being activated. And sometimes it is true aqueous tear deficient dry eye, but many times it's not. And we need to be better detectives and think about nerves. Thank you.
Dr. Galor, thank you so much. I think pain is something that we all wish we could understand much more, and you have really enlightened us. So thank you. More to come during the panel discussion with Dr. Galor and the rest of our faculty. But we are going to move forward to the next segment of our course. That is the inner sight relaxation. So for those of you that are first timers to the course, welcome. What we do here is something very different from what you're going to see in any ophthalmology course till to date that I've witnessed. And that is to take a few minutes, 10 minutes, to close your eyes. Feel free to keep your videos on or off. That's up to you. But take 10 minutes to sort of go within yourself. You know, there's a lot we can talk about the eyes, the external eyes, what we can see. But especially in the midst of COVID, we're really starting to realize that there's so much within ourselves. There's so much of a discovery, so much to learn about who we are. And I think many of you already had those experiences through these past 6 to 9 months. And so this time is for us to rejuvenate, as well as to spend a few moments of it to share our loving vibrations to one and all, because there are so many that are suffering in this world. So that collective group vibration, may it reach out to those in need. So without further ado, the Inner Sight Relaxation by Dada J.P. Vaswani.
Fulfilling, peaceful life. It helps you discover who you really are and what your true potential is. It enhances your ability to face life and its challenges. Meditation is not strenuous or difficult. It is simple and life-changing. The positive energy and healing vibrations of group meditations are tremendous. The force of group meditations has a great impact on every member of the group. Meditation begins with relaxation. Most of our time we are tense without realizing it. We need to relax consciously, allowing the stressed out and exhausted mind to rest. There are many ways of relaxation. Each one of us must follow the one that best suits him or her. I will but indicate to you today one simple method. Sit in a comfortable posture with the back straight as far as possible. Let the back, the neck, and the head be in a straight line. Close your eyes and take a deep breath and exhale. Do this a few times. Let your face wear a smile. Now sit still and breathe normally. Imagine yourself in the loving, the immediate, and the personal presence of the Lord, your beloved. You are sitting at his lotus feet, your arms around his ankles, your head resting on his feet. Say to yourself, here is true rest. Here is true relaxation. Now, relax the body, every muscle of the body. To relax a muscle, you must first tighten it and then release it. Remember that all the while you are in the loving, immediate, personal presence of God. We will now move from one limb to another by tightening it and then releasing it. Let us begin. Bring your attention to your feet. Tighten and relax. Legs. Tighten and relax. Buttocks. Squeeze tight and let go. Abdomen. Tuck it in and relax. Chest. Expand and relax. Shoulders. Lift them upwards and drop them down. Raise your arms and drop them. Turn your attention to your neck. Gently turn it from one side to another. Arms stretch tight and relax. Hands tighten into fists and relax. 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 Let go. Let go. And let God. Now tighten your whole body and relax. Repeat this 3 times. Take a deep breath. Allow your stomach to expand. As you breathe in, hold the breath for a few seconds and then breathe out through your mouth, allowing your body to completely relax. Now rub the palms of your hands together and gently, very gently, place them on your eyes and open them. Continue to smile. Thank yourself for this beautiful gift of a few precious minutes of peace. Slowly turn your gaze around and become aware of your surroundings. This is the end of the meditation. Om Shanti, Shanti, Shanti.
I thank everyone for joining me on this journey. You know, my master, Dada J.P. Vaswani, whose voice you heard, he used to teach us that we should enter complex and leave simple. How many questions do we have on a daily basis? So many. How many trials and tribulations do we all go through? So many. But with just 10 minutes sitting in silence, spending that time with yourself, PQT, as you used to say, personal quiet time, that journey just becomes so exciting and The trials and tribulations just become more as a fun part of the journey. You realize why you go through what you go through. So thank you to each and every one of you. But speaking about entering complex and leaving simple, we have Dr. Shetty with us, who is going to be delivering for us the topic, Lessons Learned, Complex Cases of Dry Eye Disease. Dr. Shetty is a corneal refractive surgeon and a clinician scientist with a keen interest in keratoconus and corneal ectatic disorders. He has been practicing high volume refractive surgery for over a decade now. Dr. Shetty obtained his FRCS in Glasgow, Scotland, UK, and is the chief mentor for the dual academic program PhD and clinical fellowship at the renowned Narayan Nethralaya Eye Institute. He has over 180 publications in peer-reviewed journals and is on the editorial board of the Journal of Refractive Surgery. Dr. Shetty, we hand it over to you.
Thank you, Dr. Ashiana. Thank you for this wonderful meeting. And also thank you. I've been also a big follower of Dada Vaswani from my medical school days. It's tremendous power in his thought process, very simple man, and his teachings are really profound. Thank you for bringing this again today. My talk is about lessons learned, and these are my financial interests. Let me start with three components of dry eye. We always talk about tears in optics as the phantoms of your vision. The reasons they're called phantoms of your vision because they exist, but you don't see them. The Ghost Who Walks has always been associated with Phantom Comics, so something similar to it. This is a 26-year-old male coming for LASIK surgery. And 3 months later, complaints of blurs, clearness, halos. And these are the typical complaints you'll see in these patients. The quality of vision was good, the aberration was good, the laser was well-centered. And you can see that this is a very well-centered laser. This was a normal epithelium, and all these parameters were healthy except for a small T-bud changes, but mybographies were perfectly healthy. So that is where we need to really look at understanding the optics. This is a HD analyzer called Optical Quality Assessment System. Very useful tool because it looks at the tear film breakup time and how your point spread function is. Point spread function looks at how the light scatters with your break in your tear film. This is normal. This is your first blink and to the last blink. And you can see that anything less than 1 is perfect. When your tear film is not good, you can see this kind of a picture. It's dropping, and this corresponds to your poor tear film. And this is a perfect one, which looks at your perfect tear film, which means your perfect optics is perfectly healthy. This is your blur, and this is your normal tear film. And this particular patient had a very, very poor tear film, which was causing this. And we all know tear film can cause poor optics. But this particular imaging system, which is very useful for me in my dry eye clinic, it pinpoints the real effect of tear film on the optics of your eye. And this is exactly what the same thing I showed. And this is what happened after we treated him. In this particular patient, I treated LipiFlow. And you can see that this is still in the we are close to 8 months now. And this is the kind of stability he's having of his tear film, and that complaints about glare and halos completely disappear. So what I'm trying to say is put a lot of efforts to understand the optics of the tear film. We did, the previous speaker, Dr. Annette, mentioned about the component of pain, the component of tear film, the molecules in it, but the optics is very important. This is one major lesson which you'll learn. And many times, these medications do work well, but we have to keep giving them for a long time. And in this patient, what we did was the LipiFlow, and this is what really happened, and it really helped in particular patients. So the medications help to treat the disease, but we need to have something to treat the optics of the system. So that is a one lesson learned. I'm happy that Annette mentioned about the corneal nerves. My journey with confocal microscopy and corneal nerves is close to 14 years now. I've been working on it on different platforms. There are two different kinds of patients. One complains of dryness, no contact lens intolerance. Other one has contact lens intolerance. Both of them want refractive surgery. And you can see that one patient who has no contact lens intolerance has T-BUT more than 5. Everything is normal. But here, this patient, you can see that the OSDI is very high. And what is interesting here is we always look at the meibography. This is a healthy meibomyography. This is an epithelial mapping. Poor meibomyography, meibomian glands, involves a lot of epithelial change. So one of the big lessons we have to understand is it's just not the meibography which helps to look at your ocular surface change. Your meibomian glands and tear film abnormalities change the epithelium from poor to good. And Aneth has shown about it, and we started looking at the dendritic cells. And what really happens is there will be a lot of molecular changes which we publish in these patients. Imagine this patient undergoes LASIK surgery, one which is a contact lens intolerant to the tolerant one, and see what happens. The nerves he mentioned are filled with more dendritic cells, absolutely no nerves here. And what happens now, a very increased OSDI, and the epithelium completely messes up. Why do you have an epithelium which is messing up? Because there is a very, very beautiful hemostasis between the nerves and the epithelium. The nerves help the integrity of epithelium. A good regular epithelium needs a good nerves, and this helps in healing. And you can see the amount of irregularity and see the cornea here, all the dendritic cells, no nerves at all. So it's a very, very classic healing patterns. And what happens then? Your tear film breakup starts, this drop starts. This is a healthy one. The patient starts complaining of glare, halos, night vision problem, regression of power. And you can see all this happen. So it is very important that a healthy nerves is very important in the regeneration of not only the health of the epithelium and the ocular surface, but it also helps in making the patient happy or unhappy, and which also means looking at the tear film and optics. So a patient who comes to you with a contact lens intolerant, who just wants a refractive surgery, is a very bad patient to treat immediately. You have to look at pre-treating them. So these are the few things I do. Look at low-dose doxycycline, low-dose steroids for a few weeks or sometimes month. Treat them with cyclosporin at least 4 to 6 weeks prior to taking up for surgery. I bring the OSDI down and then I take them. Why do we need that? Because when you do that, you are bringing down the inflammation, you're bringing down the dendritic cells, you're bringing down all the molecules which will create stress on the system. When I say stress on the system is to heal. When you have a stress, you don't heal. So pre-treating a patient who comes to you with a poor ocular surface and a high OSDI in a contact lens intolerant patient, jumping and doing a surgery immediately because you're not tolerating a contact lens is a very, very difficult thing to do, difficult thing to manage post-operatively. So the second important point is the contact lens intolerant patient could have so many factors, the healing could be completely different. The third point is a very interesting case which has a mix of multiple things here. It's a little complex, so we can probably discuss it later also, but I'll try to summarize in the next 2 minutes. Is a patient of 22-year-old female, wants laser surgery, vision 6.6. Everything is perfect. A mild T-BUT low, dropout, mild one, but this can be expected in a contact lens. But again, a contact lens intolerant patient. But this is interesting. What is interesting here is she has this donut-shaped pattern of epithelium. This could be part of a contact lens, but I made her to stop lenses for more than 2 or 3 weeks, and then I called her, so it may not. So there's some amount of elevation, some irregular epithelium. But what is interesting here is biomechanics was normal. The BAD-D was a little abnormal because of this pattern and this epithelium. It's expected. What do we do in this patient? We always look at a topography as how people look at an elephant. They pick up one thing and say that, okay, this is wrong, and they make a whole picture of it. So I always say refractive surgeons always look at, we are all 6 blind men and an elephant. We are all only picking up one side of it. So this pattern has been described in keratoconus. This is a donut shape. So this is something which didn't make sense. We were a little suspicious. But the biomechanics was normal. It didn't look keratoconus, but we also work on something called as a polarization sensitivity, which looks at the collagen imaging. This is a prototype machine which looks at the collagen. And we found that the collagen was normal, the healthy. It was not a keratoconic ones. So we didn't know which was telling the truth. And we had done work from the epithelium itself. So what we did was we decided to do a PRK on this patient. And when we do a PRK, my PhD was on looking at the epithelium and all the biomarkers from all the epithelium work. So I took the epithelium of this patient, and what we found very interesting was the collagen in this patient was normal, which means that the polarization OCT was telling the truth, and the biomechanics was bang on. It means that there was no problem in the collagen. That is very good news. But the MMP9 from the epithelium was very high, which means that is why your epithelium was behaving extremely odd. And you have two markers here, the BAX and BCL2, which is the marker for epithelial regeneration. That means when you have more of them, the epithelial cells work in a very erratic fashion, which means that is the reason why you have those kind of pattern. So you have an MMP9 high, you have these two genes high, but what was interesting is the lysyl oxidase. My whole PhD was on this. It's what binds the collagen. So lysyl oxidase is the first sign of change which can cause a patient becoming keratoconic. So what this patient had was maybe an early sign of keratoconus in evolution before even it had changed the collagen. And lysyl oxidase can affect real changes. These are my slide, which shows that higher level of MMP in your tears or epithelium can cleave the lysyl oxidase and make it keratoconic. So this may be the earliest sign which may be picked up where there could be an inflammation driving it. And these patients would probably need a different level of treatment. And I'm sure Vishal Janji is speaking about biomarkers in future. This could all be picked up from tears. And we could probably, instead of my case, instead of doing from the epithelium, we should probably do it from the tears, pre-treat them and take care of it. This is what would be the future of the real dry eye treatment, where you can pick up things. Like I said, a simple MMP9 can have an effect on collagen and lysyl oxidase, and this patient could be the earliest sign of how a patient suddenly shifts from a normal to a keratoconic eyes. And this is the kit which we're talking about, which probably will be released next year. And the molecular markers are the future. Abnormal epithelium is a factor in dry eye. And optimizing outcomes, we have to have an algorithm which is just not based on the OSDI or TBUT or the Schirmer's. I think we should probably look at multiple other factors. Thank you.
Dr. Shetty, that was really fascinating. And I just posted on the group that we should, as you know, the faculty during the panel discussion, definitely talk about some of those cases and sort of how we would handle that. So stay tuned, because I think those cases brought up some really interesting points. So next up, we have Dr. Janji, Vishal Janji from the University of Pittsburgh, who will be giving us the tear film biomarkers. He is professor of ophthalmology at the University of Pittsburgh School of Medicine. He completed his ophthalmology training from the All India Institute of Medical Sciences, AIIMS in Delhi, and his fellowship was from the University of Melbourne. He is an associate editor of Ophthalmic Research Journal and section editor for the British Journal of Ophthalmology. And in the time that I've gotten to know him, he's just a really wonderful, wonderful human being. So Dr. Janji, thank you so much for being with us today.
Thanks so much for inviting me, Ashana. This is really nice. It's good to see familiar faces. So unlike the previous two mean examiners, I'm going to be a little easy.
Thank you.
We'll see. So inflammatory cytokines, this is a hot topic. It always has been a hot topic, really. And to me personally, it means a lot because we are always looking for more diagnostic modalities and management of dry eyes. Particularly very excited about what Anat has been doing for such a long time, and she's an authority on neuropathic pain now. And that's the reason I typed that call Anat, Dr. Galore, in my chat box. We're still looking for good cytokines, good biomarkers that can be used to diagnose difficult cases of dry eyes, especially the few that Rohit has in his practice, and I've heard him present. very difficult cases, which ultimately were diagnosed to have just recalcitrant, dry eye or neuropathic pain related to dry eye. Okay, let's start with a relatively easy one. Which of the following is an anti-inflammatory T cytokine? A, interleukin-5, B, interleukin-6, C, interleukin-12, and D, interleukin-17.
Alrighty, so participants, go ahead and chime in on the chat box with your best guess. We'll give 10 seconds on that.
Right, well, it's, and even if you don't know, it's easy to guess because they're all numbers.
It's about 50-50 B and C is what's happening.
There's actually interleukin-5. So anti-inflammatory cytokines are predominantly related to action of Th2 helper cells, and they lower the inflammation in tissues. These pathways actually have been studied in other systemic diseases as well extensively, actually more now in cancer cells as well. Interleukin-4 stimulates the Th2 differentiation, and interleukin-5 is secreted by the Th2 helper cells. They basically, the good part is that their levels have been found to correlate with the disease symptom severity. The other interleukins, other cytokines in the same group are interleukin-10, interleukin-13, and TGF-beta as well. Even though they suppress the T cell immunity and they stimulate the goblet cell production, many of the studies have still found that the levels do not, across populations, they don't correlate very well with the disease severity, and they might be very different if you study different populations in terms of disease and geographical location as well. All right, so sorry, that was a difficult one. Let's see if this one's a bit easier. Which of the following cytokines is increased in acute Stevens-Johnson syndrome? Interleukin-6, interleukin-22, interleukin-23, and interleukin-4.
Okay, so A's across the board.
I feel so much better now. All right. Well, interleukin-6 actually, it's SJS acute and Sjogren's syndrome both. It's quite sensitive. Interleukin-6 decreases tear production and raises the inflammatory levels of cytokines, inflammatory cytokines in the tear film in patients with Sjogren's syndrome and also with acute SJS. They are very well correlated with the ocular surface parameters in these patients. Additionally, interleukin-1 beta, it decreases tear production and induces synthesis of acute phase proteins such as interleukin-6. So they're actually correlated with each other. And interleukin-1 beta is very sensitive marker in patients with acute SJS. I found this slide many months ago in a review article, which was in a non-peer-reviewed journal. And it basically, there's not much information on this to absorb, but it tells us how easy it is to get lost in the sea of cytokines. Fortunately, we have a couple, more than a couple, which have been or will be used in very near future as targets to manage dry eye disease. Lactoferrin, lecithin, and nerve growth factor. These are the three cytokines that have been used or will be used in very near future as targets of dry eye disease. But if you look at the list, it's really, really big, and it can be really confusing and overwhelming. So that was the purpose of showing this slide. Okay, the next question. Which cytokine can be detected using point of care testing? This is really easy, and actually previous speakers have given so many hints. It's like an open book test. A, TGF-beta, B, MMP9, C, interleukin-10, and D, interleukin-2.
Most have given the answer B.
Very good.
90%.
So MMP9, as Rohit mentioned, one of the most commonly talked about marker in dry eye disease, in keratoconus, in almost every ocular surface issue. And it was sort of, 10 years ago, when people started talking about detection of MMP9 and correlation of MMP9 levels in tear films and disease pattern, it blew the market. This slide basically shows the vicious cycle, how inflammation and release of MMP9, it can correlate with symptoms such as dryness, itching, irritation, blurred vision, light sensitivity, foreign body sensation, excessive tearing. Then the hyperosmolarity of the tears will actually go back and release more of these inflammatory cytokines, which will cause more tear dysfunction, instability of the tear film, which will cause the nerve stimulation and cause neuropathic symptoms as well, which will again cause more cytokine release. And systemic diseases, which are now, again, a very hot topic: Sjogren's, rheumatoid arthritis, thyroid ophthalmopathy, lupus, and more recently, ocular graft versus host disease, which is my favorite topic. Now we see more patients with ocular GVHD. Not that they are more patients of ocular GVHD, it's just that we now have more understanding of ocular GVHD in general and ways to treat ocular GVHD patients. MMP9, just briefly, it's a proteolytic enzyme that these enzymes are produced by stressed epithelial cells on the surface of the eye. It's a very non-specific inflammatory marker, and look at the range, 3 to 41 nanograms per mil, but it does correlate with clinical findings in dry eye patients. This is a very good paper published more than 10 years ago, which basically showed that if the levels are more than 40 nanograms per mil, there is a high possibility that you're looking at inflammatory dry eye. This is what is available in the market. Inflamadry, I started using Inflamadry again about 10 years ago when I was in Hong Kong. It was not available in the United States at that point. It detects elevated level of MMP9 in tear film. It's a rapid test, takes about, I would say about 20 minutes, not 10 to 12. It's very easy to use, looks like the pregnancy test though. There are 2 bars there. It's in office, point of care, as I mentioned. Cost, it depends where you are. Last I checked, it used to be about equivalent to about $20 US in countries like India. It's single use, and sensitivity is about 85% with specificity of 94 to 95%. A short video of how easy it is. I'm just gonna fast forward that. So basically, no anesthesia required. You can ask the patient to look up once you have collected the tear film, you just put it back into that cassette and then dip that into the solvent, and then you wait for about 20 minutes or so. And then you look for those 2 bars. So it's negative basically in this patient. So it's as easy as that. Okay, the last question on the topic that I just mentioned is really my favorite and really hot topic. Which of the following cytokines correlates with disease severity in ocular graft versus host disease? Interleukin 10, interleukin 6, TNF alpha, and all of the above.
100% of the audience agrees with the D, all of the above.
Yes, it is all of the above. So GVHD, really, really interesting disease. I'm sure everyone on this panel has seen a few patients already with GVHD. Last year, there were 2 clinical trials. Both of them have been closed. I think the more interesting trial was, Anat knows about this, was discussed in the GVHD meeting last year. I'm not even sure, Anat. It was October last year, maybe. And there was another one from Cambium, which is based in Chicago. More than 50% of patients who receive allogeneic bone marrow transplants, they develop chronic GVHD. I mean, look at that. More than half of these patients, they have this debilitating condition. The risk of chronic GVHD is known to be higher in peripheral blood stem cell recipients as compared to if you have a patient with BMT, bone marrow transplant. And up to 60 to 90% of these patients, they have ocular involvement. So anyone who develops systemic GVHD has a really high possibility of developing ocular GVHD. And actually, I would agree more with 90% than 60%, because some of these patients with ocular GVHD, fortunately, they have mild involvement of the ocular surface. And, we really don't know what correlates with this mild, moderate, and severe ocular GVHD as far as their systemic involvement and systemic treatment is concerned. I know Sandeep Jain has been working a lot on ocular GVHD and possible treatments for this condition. GVHD, dry eye disease, is mainly due to aqueous tear deficiency, but histology shows inflammatory destruction of conjunctiva and lacrimal gland with fibrosis. That's a key word there, fibrosis. So many of these changes, they are irreversible and they result in tear production deficiency in these patients. So that was the end of my presentation. Thank you all for participating.
Thank you so much, Dr. Janji. That was amazing. Next up, we have our finale speaker, Dr. Krish Muskati. Dr. Muskati has a renowned background. He has been the past president for the All India Ophthalmological Society, AIOS, of the International Society for Manual and Small Incision Cataract Surgery, the Cornea Society of India, the Bombay Ophthalmic Association, Maharashtra Ophthalmic Society, and has received numerous accolades, including the Lifetime Achievement Award from the International Society of Cornea and Keratorefractive Surgery. I hand it over to you, Dr. Muskati, to guide us on the next in the pipeline innovations in dry eye therapy.
Thank you, Ashana, and it's great to be amongst all of you. I've thoroughly enjoyed the talks and the quizzes so far. I love conducting quizzes, been doing it for the All India for almost 20 years now, so it's great to be answering quizzes and getting most of my answers wrong and still enjoying myself. No one really knows what's going to come out of these pipelines. They're all so opaque. They're all leading to nowhere. And we don't really know which of these pipelines are going to develop nice openings and come out as actual practical innovations which we can use in dry eye therapy. Also, whether something is in the pipeline or is actually in your practice really so much depends on where you're located. If you're in Baskin Palmer, or if you're in Dukes or in Wilmer or something like that, you may be even handling some of these things. If you're in a small rural area in India, even the cyclosporin may appear to be an innovation which will one day seep into your practice. And let's classify these into three parts. So first we'll talk about dry eye treatments and the different ways of delivering dry eye treatments. And here, the new kids on the block are nanotechnology, some things which have been around but not really caught on and are catching on now is sustained release medications, lacrycerts, and very interestingly, contact lenses being used for drug delivery. So nanoparticles, the University of Waterloo did some pioneering research and developed a muco-adhesive nanoparticle system. These particles are capable of adhering to membranes like those seen in the eye. We know about our eye membranes. And these particles are themselves synthesized from the things which you can't easily pronounce, so we won't mention those. But basically, they become adhesive. And this adhesion prevents these nanoparticles from being washed away for almost a week. Then there are those nanomicellar solutions. The hydrophobic nature, you know that cyclosporin is hydrophobic. So it has its limitation of going in through the aqueous. So these nanomicelle formulations, they solubilize these hydrophobic agents. So cyclosporin, which is hydrophobic, becomes able to penetrate the aqueous because of this the nanomicelle formation, because the drug is not naked. It's entrapped within the micelle structure and it creates a clear aqueous solution. It fools the aqueous into thinking this is a hydrophilic substance and allowing it entry. I'm trying to simplify something which the guys in the labs make very complex. So this OTX 101 0.09% cyclosporin is already come out and it's using this nanomicellar technology. So when they did clinical trials, they found that a much higher level of cyclosporin could be measured in the ocular tissue after you administer this OTX -- compared to the conventional therapy where you gave the cyclosporin in the lipid base as it used to. So you could even use this technology for other particles like rabamipide. So rabamipide itself, the particles are ellipsoid, small particles, and they could apply it to the eyelids and deliver it through the lacrimal fluids, through the meibomian glands. Then the other technology which was there actually when we was studying in basic medicine, MBBS, the ocular inserts in the 60s and 70s, which came in and then went out for some reason, and they're now making a comeback because these Lacrisert inserts are preservative free. There are no known drug interactions and can even be used by contact lens wearers. And contact lenses themselves, the newer extended wear contact lenses, a couple of universities are experimenting with these, and you could deliver, up to now they were using it mainly for anti-inflammatory and antibiotics and pain relievers, but the same technology can be used for dry eye, and it has been used in laboratories. So those were drug delivery systems. Then newer drugs itself, that's the second part of my talk. So the Liftigrast, the nerve growth factor, topical androgens, these are some of the newer drugs. Some of them have seen the light of day. Some of them, perhaps due to a collusion with Big Pharma, refuse to see the light of day. Liftigrast, not yet available in India. We know that it's an anti-inflammatory because we know that inflammation and T cells are known to play a big role. And Liftigrast is a small molecule that serves as an ICAM-1 mimetic. It binds, by binding to the LFA1 on T cells, the Liftigrast inhibits the binding of ICAM-1 and thereby inhibits the inflammation associated with dry eye syndrome. So this is one more anti-inflammatory to be added to the cyclosporin and to be added to the trehalose that we have, which act on different pathways, and I'm sure it will soon be available in India as well. Nerve growth factor, which has come in, the Oxervate, which has come in, started out, I think, in Europe, and it's still extremely expensive, into the hundreds and thousands of euros if you want to complete a full course, but it shows great promise, especially in our patients with neurotrophic keratitis, where it promotes nerve regeneration and the healing of very recalcitrant corneal epithelial defects. And my favorite is topical androgens. They were doing very well in FDA trials, and then the small company was taken over by a big multinational, and somewhere along the way, the androgen never hit the market. And I think there are more commercial considerations which are preventing topical androgens. We know that androgen is the only drug produced by the human body which can regulate our tear secretion. Cyclosporin is a drug which is artificial and which can be put in to do the same thing. But it would be so wonderful if you could get topical androgens, which would be very effective. And I'm still dreaming of the day when it will be commercially available. And the third aspect of treatment, so we talked about drug delivery systems, and we talked about drugs itself in the pipeline, and certain treatments. Some of them are already available, gadgets like the Intense Pulse Light, the Tixil, the LipiFlow, and the newest kid on the block, the EI, which are showing great promise. Initially, we knew they were working in 60 to 80% of the cases. We didn't really know how they were working, but a lot of research has come in to show us that there is photobiomodulation, as it's called. We use very big words to confuse the audience. Imagine telling a patient that we're going to treat you and it's going to cause photobiomodulation, but don't worry, it won't hurt. And the poor patient thinks it's something akin to something very complex like cancer therapy, and he's willing to pay the price up front. But it does work. Perhaps it has a thermal effect. There's some amount of heating on the lids. Cells absorb light, photons. There are several theories which are available now, but we are learning more and more about that these therapies do work. Rohit also talked about LipiFlow, helping patients in post-LASIK. These do work in patients in recalcitrant cases. iLight have been not only with dry eye, but they're now using it for post-blepharoplasty, for Demodex, for blepharitis, even for chalasia and STI. We don't have the time to go into all these details, but they're finding multiple uses to show that you can get value for money if you purchase one of these. No commercial and financial interest. And Tixil is one which came out from Israel. I've used this. It's a nice, handy, small gadget. You don't need that mask. You just apply the 5 shots on each lid, so about 20 shots in all. and it works fairly quickly, and there's no heating involved outside. And then you have the EI, which is, as I said, the latest kit, which does practically the same thing. It's been around now for a couple of years in some countries, and it's yet to hit the Indian market. So it's been proved that the only new thing as compared to the IPL is that it's a train of pulses which come in, and it triggers the liberation of several neurotransmitters, and it doesn't directly affect the meibomian gland. It's more an indirect action, and you need to do it on the suborbital and the zygomatic region, where the parasympathetic sympathetic nerves are stimulated. To summarize, we've talked in the short span for three things: the drug delivery systems, the new drugs itself, and the gadgets which are being used to make dry eye patients happier as time goes by, and hope some of these will gain wide acceptance all across the world soon. Thank you so much.
Dr. Muskathy, you were absolutely the perfect person for that. We have this expert group of panelists with us and about 15 minutes together. So I would love to start with diagnostic tools. You know, we're still faced with sort of this hole of correlating signs and symptoms most appropriately. So in your practices, how do you go about overcoming that? And what do you foresee in the pipeline, or if it's not yet in existence, what is going to take us? What is going to be that pathway to take us towards bridging that gap of diagnosis? So I'm going to start with Dr. Syed.
Yeah, so I mean, that's a great question. So we've presented all these different, novel modalities. We've talked about, novel ways to diagnose dry eye, different tear film biomarkers, but at the end of the day, how are we actually bringing them into our clinical practice? And I think that's the big question for all of us to discuss. And in my practice, a lot of it is based on my clinical exam, as Anat kind of highlighted very nicely in one of her questions. And that, on my exam, I'm very carefully examining the ocular surface, the lids, doing a very detailed history. And at the end of the day, a lot of my decision making is based on my clinical exam and my history and my evaluation. And I'm eager to hear how other people do it, but kind of that for me takes kind of paramount importance.
Yeah, I mean, I think that, so there's, of course, there's the treatment aspects, which we'll save, but in the diagnostic realm, I think that not every patient comes in saying, my eyes are red, irritated, and I have dry eye, right? A lot of times they come in with non-traditional complaints, blurry vision, fluctuating vision. And so, when we look at diagnostics, a lot of it is cost dependent, right? So some of these are cost prohibitive tests, or there's not reimbursement and there's only access to them at a specialty center. And that's okay. I don't think you have to incorporate everything to adequately diagnose dry eye disease. I would say, currently what we have available, so MMP9 and osmolarity are the most mainstream. They're CLIA wave tests. But there is a cost associated with them. And for practices that, maybe don't want to dive into spending the extra money on a diagnostic, questionnaires are really helpful. I mean, there's so many, it depends on your practice. If it's, a high volume practice and you want something to rapidly screen, I think questionnaires and osmolarity are probably the two tests that I would recommend incorporating. One, because there's always downtime in an eye exam, right? So whether they're dilating or waiting for you, it's usually the one in my clinic, there's plenty of time for them to fill out a questionnaire. And then osmolarity, I like to use it as a screening test, less as a measure of something that I follow over time, because it has a very high specificity. And so if you have a normal osmolarity, but yet have someone with symptoms, that points to something besides dry eye. And it encourages me to look for non-dry eye causes of ocular surface disease.
I think the really important thing to ask is, what do our point of care tests need us to do? And so for me, it's not about diagnosing dry eye, yes, no, because it's not one thing. It's looking for contributors, explaining what the patient is coming in with. And so I really I wish I had more. Every time I hear Rohit's talks, I always get jealous that he can go down and look at these little molecules and understand so much. But I have MMP9 as a qualitative test, even though you can quantify the strength of the pinkness. And that correlates with the amount of MMP9. And to me, that helps me understand if there's an inflammatory component to the complaints. So to me, that's just useful. And I complement it with my confocal microscopy where I'm looking for those activated dendritic cells. Because to me, what I'm trying to look at is I'm trying to look at different components, of which some I can look at clinically, like Zeba mentioned. I can look at, tear volume, I can look at staining, and some I can't. And so I use my point of care test to understand what is contributing to my patient, because inflammation is nonspecific. Someone who comes in with acute conjunctivitis will also have an elevated MMP9. So all of these tests need to be incorporated with the clinical picture and with a clear understanding of what you're going to do with the information. And as we develop more point of care tests, we're going to be able to understand more about what is contributing to individual patient. But I actually totally agree with Dr. Shetty that the way to go is precision-based medicine, because we're going to talk about therapeutics. And one of my biggest pet peeves is we have no way to link our diagnostics to our therapeutics. So who is going to respond to an anti-inflammatory? And if so, would they do better with cyclosporine or lifitegrast? And I get really excited when I look at people who are looking at these molecular signatures and then telling me that that is going to be somehow predictive of what a patient is going to respond to. And that, I think, is the future of dry eye. So keep up the good work, Dr. Shetty.
Apart from all the tests, all the discussion we had, there are two things which is very important for me related to dry eye, but not the dry eye per se. For example, what I've noticed is many times patient comes to you with big symptoms that I have eye hurts and pains, and you have a poor ocular surface, you relate everything to it. But when my first case was on the tear optics, what happens when your optics of your tears break down? The lens starts accommodating more. So invariably, we have noticed that 99% of my dry eye patient have accommodative issues. What happens when you have an accommodative issues over time? They start developing convergence or accommodative insufficiency, and that starts hurting their eyes more. They start seeing double. So what do you blame in? You blame the tears and keep pumping more. So we have to come out of this concept. I think, including myself, we are all blind people looking at an elephant and touching one part and say we found an answer. I think if you really look at it, most of my dry eye patients now get better with orthoptics exercises. I send them to a good orthoptics evaluation. Many of them have fusional issues. Many of them have convergence issues. Many of them have accommodative issues, all related because you are trying to focus and defocus all the time. Dry eye does not get better in most of them, but the symptoms completely disappear because most of them, they say that they just cannot explain a fusional issue or orthoptics issues because everything they blame it on dry eye. And I believe that apart from all the advanced tests we are doing, we have to go back to the basic root of telling people that orthoptics evaluation should be the cornerstone of a dry eye evaluation. And now every single patient of mine has to get a very good orthoptics evaluation, which is not just a near point convergence and accommodation. It's about a complete orthoptics evaluation. And that, I think, should be the main step in this thing. And the second is what Dr. Anat mentioned, the addressing the psychological component. We don't address the psychological component. We just take care of it. Most of them do suffer from a lot of psychological issues. And so dry eye, which is tough dry eye, needs to be managed, according to me, not with more investigations, but with very basic tests, which sometimes we miss in our practice.
Dr. Shetty, I want to also highlight the 22-year-old refractive surgery patient in just a moment. But Dr. Muskathy, Dr. Janji, do you want to chime in as far as diagnostics in your practice?
Yeah, I normally ask. See, I have a lot of referral practice. So if I have a patient who's been to 2 or 3 doctors and come to me with dry eye symptoms, I will typically ask them about their sleep habits and about, try and gauge their personalities, as Dr. Rohit said. And hand on the shoulder and telling them very positively that you will get better, and calling them quickly, means within a month, calling them back, and irrespective of whatever the tests I'm doing, whether it's the OSDI or whatever, I will tell them you are getting better. Now, that's the first time they've heard someone say they're getting better. So whether they are or not, my telling them that they're getting better really does help them. So I totally agree with Dr. Rohit that there's a lot of psychological component, especially to these recalcitrant ones who've gone doctor shopping. They're almost ready to commit suicide there, and we need to boost their psychological makeup.
What we did not have time to discuss, and it has been indirectly covered, is the psychosocial impact. In the United States, I'm sure everyone on the panel who practices in this country agrees that a large proportion of these patients, they are on antidepressant medications already. And SSRIs are known to cause dry eyes. I've got tons of patients who've been on SSRIs for more than 10 years and they have dry eyes. It is important to sort of liaise with the primary care physician or whoever else is involved to look into that aspect as well. But as Zeba said initially, I'm reminded of a presentation in UKONIA in 2014 where there was a discussion of what's the best way to diagnose dry eye, and clinical exam and proper history was top of the list and still is the same.
Absolutely. Dr. Gupta, along the lines now, we're moving towards the psychosocial and the discussion point of view. You know, you gave an amazing talk about refractive surgery and how do we manage dry eyes. So when it comes to patients that feel dry symptoms post-operatively, what's that counseling like? I mean, pre-operatively and post-operatively, how are you dealing with that in your practice?
Well, I think the number one thing is with every patient that comes in for refractive surgery, I talk to them about the risk of dryness. And we are screening them for the dryness, but despite screening, I tell all patients that I expect you to be dry afterwards. And often it'll be just a few months, but you don't live in a bubble and your body can change and you may develop dryness later. Or it might be related to the surgery, and ultimately it's up to them to decide, you know, whether that would be something that would be bothersome. But, you know, as Anat pointed out very precisely, is that, you know, some patients have this predisposition, right? So we do LASIK surgery on them, and that tips over their nerve remodeling or their perception of pain. And while it's rare, I mean, this is not, you know, maybe in an academic center, we see a lot more of this than in an average practice, but there are it just doesn't happen very often, but there are some patients that come in and, you know, often we think it's dry eye, but they develop this, you know, abnormal sensation that gets labeled as dry eye. So I don't spend time talking to my patients about that. That's very rare. But, you know, I think when patients already know to ask us about dry eye. There just isn't a patient that comes to my practice that doesn't say, well, what's the risk, or, you know, what should I expect? But I think appropriate counseling, and management post-op. You know, I tend to be someone that tells patients, okay, you have to use your tears. If I see that they're dry and they're symptomatic, I'll have a low threshold to add additional treatments, prescription therapies. And I think that managing that early on makes a difference.
Thank you. So Dr. Shetty, can we pull up that case that you had? One of your cases was on the 22-year-old patient with, you know, about to undergo refractive surgery, contact lens intolerant, donut-shaped pattern to that epithelium.
So basically, this case was interesting because of this pattern here. What happened was this case had a very unusually donut-shaped cornea in a very healthy-looking eye, and this had a normal biomechanics. So, like I said, we wanted to really see, because this donut-shaped pattern has been classically described in keratoconus, early keratoconus. You don't see this kind of thing. And what we wanted to see, this is how it looks, and you can see this is the same patient. The polarization sensitive OCT, which is, we have this in our lab. This is something which it looks crude because it's not commercially one, it's made by parts, bits and pieces made together. you look at this, this is how a collagen image looks. And you can see this is your periphery and you have a different collagen. So what happens is your central collagens are like this and peripheral collagens are like this. It's more tightly bound. And that is the color pattern you see here. The yellow is this and the blue is in this. This is how electron microscopy of your collagen is. So when you have a disease, what happens is that this collagen will completely degrade and you'll see it as gaps out there. So this is what we see. And because we were looking for whether this is something to do with the disease eye, we wanted to do a collagen imaging, and we found that the collagen were normal. So it is not a keratoconic eye, even though the epithelium looked like that at this point of time. So I decided to do a PRK. Like, my work is all on what we discard. So we took out those epithelium. This is all the work. And there are multiple things you can do when you take out a tissue. And this is anyway, we looked at all the genetic markers. Epithelium, you can look at the markers for collagen, lysyl oxidase, which binds the collagen and everything. So the really new interesting fact is the collagen was very high in this patient. Obviously, I don't know whether it's high or low, but that means that what the polarization sensitivity was showing was perfectly all right, because what your collagen is showing in your imaging is actually picked up by your genetic marker. But what was interesting here is the MMP9, which Dr. Vishal mentioned. The MMP9 actually was very high compared to the controls here, which means that there is some ocular surface inflammation happening. MMP9 high always cleaves the locks, which is always the opposite. That is what has been traditionally known. And especially in post-LASIK ectasia and in keratoconus, this is the real mechanism. High MMP9 and very low locks. And we did this experiment where, if you look at this, this is a very nice experiment. In the interest of time, I did rush. We did this Western blot. You can see that as the MMP9 increased, the locks level actually reduced. And we did this on a model of keratoconus. So what we believe is, if you have a high MMP9s, your collagen and lysyl oxidase completely grossly reduces. And you can see that as the MMP9 increased, your collagen also started showing changes. So this is something which we published, and this patient exactly had the same thing. High level of MMP9, high level of thing. And all it started off was this map, which gave us that there is something not right in this patient. And it's just not one case. We have had many, many cases on similar lines. But what I'm trying to say is, this is how a disease is in the phase of evolution. And what we do, what we actually get is, when the disease has completely become keratoconic, we never pick it up at this stage, because most of the time we cannot. So this is something which Dr. Vishal also is one of our mentors in a lot of this program. And this is what is actually happening now in our lab. It has come to the clinic. This kit we are now doing, even though this was COVID, this lady here is one of my residents. She's taking the tears. You can see the mask now, and she's doing it. And it takes 1 hour to get these molecules. But now we want to bring it up. This panel can add any number of things. We are even trying to get a lysyl oxidase panel. We can do anything. And this is actually correlating. Why did we pick up all this? This because it correlates very well to your disease issues. So this case could be the one case where we have to really look at picking up the disease very early, rather than becoming an imaging. So that to become for example, we all know that to have a perimetric loss in a glaucoma, Dr. Quresh Maskati sir is a glaucoma person, you need at least 30% of ganglion cells to die. We need so many cells to die to become perimetric, and maybe another 20% to die to become it on the OCT. Exactly like what we are seeing is, we are waiting for a disease to progress to a stage where it is already 20-30% weak to pick up on an imaging technology. So imaging technologies is only going to pick up after you lost 20-30%, shaved it off. you had to pick up when it is at the earliest sign, maybe 1% or 2% loss. This case probably tells you that the way to go is the molecular signaling, because that will pick up even when there's a small tilt in your disease process.
I want to bring a point that I think this work is beautiful, but to me, there's a part of it that doesn't make sense, Dr. Shetty. It's that MMP9 it can't be enough, because I'm thinking about my Sjogren's patients and my graft versus host patients, that no matter what I do, I can take them from fuchsia to really strong pink on the Inflammadry, but they have chronically elevated MMP9 levels and they don't go on to develop keratoconus. So I absolutely agree with your link, and I think your observation is beautiful. What do you think that missing link is? It's MMP9 and then something else. Is it genetic predisposition, LOX variant, something in the collagen that makes it more likely to react to the MMP9? Any clues on that missing link?
I'm also not a big fan of MMP9, because it is, if I rub my eyes a lot, it can become positive because it just picks up many, many things. I feel that the missing link is the epigenetic changes in your cornea itself. Epigenetic changes. And I personally believe that is the missing link, which says, even in this patient, we did pick up other molecules like IL-2, other inflammation, all similar to what a keratoconus patient was. But only thing which makes a little sense here was the MMP9. That's why I put it up. Otherwise, I'm not so big a fan of that. But the missing link for every single patient, anywhere in the body, on inflammation is the genetics, because it's like COVID. I believe that people don't get COVID because they don't go to a cytokine storm, because they're genetically stronger to withstand that change. And there are a lot of new papers coming that genes play important role in who is one who goes into a very bad COVID versus to somebody who does not go into COVID. So I think exactly the same thing I feel is going to happen in the ocular surface and the cornea.
Ashiana, if I can just intervene in the basic question.
Yes, please, Dr. Muscat.
Yeah. The basic question, which was depending on the dryness of the eye, which procedure you would choose. I think the take-home message, especially for the youngsters in the audience, should be, depending on the dryness of the eye, am I going to do a refractive procedure? So just because there is a patient and there is money to be made, please don't rush into any refractive procedure. Even a PRK or a SMILE will worsen a dry eye. You need to spend time with the patient, treat the dry eye, bring the OSDI down to manageable levels, make the patient better if they were symptomatic. And only then, even if it means waiting for 4 weeks, 6 weeks, I've sometimes waited 2 to 3 months before I've done it. And sometimes I've just said, I'm sorry, but you're not a candidate for any refractive procedure that I would do on your cornea. So I think the take-home message should not be lost.
I want to add here, we've done work on SMILE and many other procedures. If the patient has got to predispose to dry eye, whether you do SMILE, LASIK, or whatever,
absolutely,
she will get dry eye. And we did publish this. We have that proof on that. So what I would do is that we would just bypass the whole cornea, nerves and everything, put an ICL on these patients. So you don't have to worry about dry eye as one of your factors.
Thank you, Dr. Shetty. So to Dr. Gupta, two-part question.
I don't know that in looking at the literature, whether or not you can say that PRK actually induces less dry eye than LASIK. I think that it more has to do with the patient's factors. If we look at a lot of those studies, how they were diagnosing dry eye is probably not consistent between the studies. Some would even say that if you have a patient that's dry, that it's actually harder for them to completely reepithelialize, and it's actually more traumatic to the surface to have PRK over LASIK. And so I don't know that, we can make those broad brushstroke statements. I think that, to me, it's much more of a hard stop. If you're dry, we're not going to do refractive surgery until we have rehabilitated the surface, until we can prove that, another additional challenge isn't actually going to cause decompensation. And then, third of all, that the patient is okay with potentially having worse symptoms or potentially being on a long-term topical therapy, etc. So this is the art of medicine, and there isn't exactly any sort of, predefined, okay, if you fit into this exact bucket, this is how you're going to turn out. And so, a lot of it depends on those patient factors, in addition to doing a good job identifying it and treating it before you even consider the patient a candidate.
Perfect. Dr. Gupta, we're going to start with you to do our wrap up on final pearls, final thoughts for our audience.
Well, I love that everybody is here on, I'm like, what day is it? Sunday. Here on a Sunday to, learn about ocular surface disease. Whether you're a cataract surgeon, a refractive surgeon, a glaucoma specialist, it doesn't really matter because ocular surface disease really is everywhere. And I loved hearing all of the presentations today because it gives me hope that in the future that we're going to have additional diagnostics and, additional targets, molecular targets for therapies. And that's, we're at a great position today than we were 10 years ago, but I'd love to see 10 years from now, us laughing at all these tools that we're talking about today, because there's so many better ways to diagnose it.
So I wanted to echo what Dr. Gupta said. I know everyone has busy Sundays, and we really appreciate that you guys took the time out to, spend some time with us. And thank you, Ashtiana, for organizing. This has been awesome.
Thank you for being here.
My kind of take home is to just stay open-minded. I think, I'm very early on in my career, and, obviously the things I've learned in my training will no longer, a lot of it will no longer be relevant, 5 years from now. And so as long as we all kind of stay open-minded and be open to trying new things and kind of, following what's new and what's on the horizon, then we'll stay up to date and keep doing the best for our patients.
Yeah, thanks everyone for these beautiful presentations. Let me just reiterate again, a good clinical exam and a good clinical history goes a long way. And in terms of what was being discussed for dry eye and refractive surgery, why don't we just sum up and say that if a patient has symptomatic dry eyes, no refractive surgery, no cataract surgery until that is resolved.
Perfect. Dr. Galor.
Really great points by the speakers. And I would add, think broadly and think about nerves, both in how they relate to symptoms and also how they relate to signs. It's a feedback loop. What goes up comes down. Nerves and epithelial cells are constantly interacting. They're talking to each other. And so I'm just glad to hear that nerves are being brought into the conversation more and more. I think it's great.
That, or we can send our referrals to you, Dr. Galor, one or the other. Dr.
Yes.
Muscati.
Yeah, I just want to say, don't be very dismissive of your dry eye patients who sometimes come with strange symptoms. The hand on the shoulder and the amount of sympathy that you give and a little extra chair time will go a long way in finally healing them.
Perfect. And finally, Dr. Shetty.
I did mention this in my previous 2 points, that when you look at a dry eye, don't be a blind man and an elephant. Try to look at everything as a whole, not at one point. And I've learned it myself because I was this blind person. So I think that, getting an orthoptic evaluation, a simple thing, and if there is an issue with like accommodative or a convergence insufficiency, treating it, because the symptoms may look the same. The patient may come to you with the symptoms which looks like a dry eye, but it could be different. And I personally believe that we have to really look out of the box, which we have so confined ourselves into, and go a little outside. And that will really help a lot of patients. I've had at least 2 neuropathic pain patients diagnosed, treated with multiple things, just recovered with a very good, very, very strong orthoptics exercises for fusional vergence issues. And the pain just disappeared. And even though it was classical neuropathic pain.
Beautiful, beautiful. I mean, I think we have the expert premier faculty with us on dry eye disease. I thank each one of you for being here. It's clearly evident that we've come a long way in our diagnostic tools and our management, but we do have a ways to go, because there are holes in our understanding. And hopefully, based on what each one of you are doing, and the world of dry eye disease with so many different technologies out there are definitely moving at such a rapid pace that in the next few years, I'm hoping we can see to brighter days. So thank you, thank you, thank you. And looking forward to seeing you post-COVID.
Thank you. Bye.
Bye, everyone.